I'd like to start off. My name's Ira Kirschenbaum. I am the editor of the Journal for E- Experience. Sorry, Journal for Orthopedic Experience and Innovation. I am multitasking by bringing people in at the same time. Um, and tonight we have we will call it part two, but it exists in its own right of a of a of a series that is sponsored by Ospitec, but it has great impact in the orthopedic space. And essentially, this whole series is setting new standards in efficiency and improving outcomes and facility capabilities. This one tonight is defining efficiency and achieving your goals, which I think is a critical topic. I'd like to introduce our faculty and ask them to please say a couple of words about themselves, where they're from, and something maybe about the topic. I'll start with Dr. Michael S. Dr. Michael S. is orthopedic surgeon and chief medical innovation officer at HSS. Michael, take away the rest of your introduction, please.
Thanks, Ira. Always a pleasure to hang out with you for the evening, even if it does tend to be on Zoom a little more often than you'd think, considering we live 5 minutes from each other.
Yeah.
But uh, but yeah, so I'm Mike Ast. I'm a surgeon at HSS. I also am the president of our ASC Development Network and the chair of our ASC coordination committee. So, spent a lot of time in the ASC world, spent a lot of time in the world of outpatient arthroplasty, and then really started getting involved in the concept of efficiency over the last couple of years, trying to understand how you take, whether it's a small ASC or a large academic medical center, how do you start to figure out what efficiency means to each of those places, and then how do you do a better job along the way? Because as we get paid less money to do the same thing, we're going to have to get better at doing it. And I think there's a lot of opportunity out there for so many of us, and I'm looking forward to what all the other speakers have to say tonight. So I'm sure there's a lot I can learn.
Thank you. Atul Kamath, how are you doing?
Ira, thanks for having me. I'm a hip and knee surgeon at Cleveland Clinic. I am sort of a repeat offender here. It seems like every week we're doing these, which is kind of fun. Highlight of the week. I think this is also a highlight of the sessions among this series, right? We're seeing efficiency and ASC work and innovation in that space from multiple angles, and we'll be, of course, tackling efficiency, which is a nebulous term, but also has very specific framework or understanding from each of the speakers, which will be exciting to understand and develop. So happy to participate. Thanks.
That's great. And Dr. Brian Cohen. Brian?
Ira, thanks for having me.
Oh, hi there.
I'm very unique to this group. I've performed 0 cases in ASCs in my 24-year career. I've been an employed physician for 24 years. But I like to think that I've pushed the efficiency in the employed model. So I'm trying to learn more about what's going on with this opportunity, and then also kind of impart what we've been able to do at our facility.
Excellent. Lacey Dyer.
Hey, thank you, Ira. I appreciate you inviting me into this group. I'm a nurse, and I work for Surgical Investors and Advisors, which is a development and management company for the ASC market. That is my specialty. I love it, and we have really enjoyed working with all the players here to understand how to make efficiencies in an ASC where we have a very limited reimbursement, and we need to really be efficient in our staff, providers, all of our equipment, all those kind of things. So I hope I can give you the outside look of that, not in the OR so much, but I want to show you the background of all of that.
Excellent. And Kyle Anderson from Ortho, Rhode Island.
Yeah, great. Thank you, Ira. It's great to be here. Just hearing these other introductions, I am super excited to hear about how Dr. Cohen is slugging away trying to achieve efficiency in an alternative setting. So I'm looking forward to that perspective. Kyle Anderson, I work for Ortho, Rhode Island, located and headquartered right in Warwick, Rhode Island. I was just mentioning here at the top of the call, we have about 6 ORs running, equipped for 8 ORs. We run 2 procedure rooms. We're trying to creep up the case volume that we do. We'll do about 9,000, 1,500 to 2,000 total joints, and really trying to plug away, which is why efficiency can't be more important to all of the stakeholders of the entire practice, and what makes this such an exciting topic. My role with Ortho Rhode Island is a pretty interesting blend of finance and operations. While thinking and trying to maintain the importance of the patient experience, the physician experience, the employee experience, and how do you keep your sights on that three-headed bullseye. And I think efficiency is the key, and so it's the introduction of technologies, it's sort of the maximization of the data that you have available to you, and where do you take it from there. And so I look forward to hearing what everyone has to say about the topic tonight.
It's great. So the first webinar, we talked a lot about alignment of a lot of people in the operating room, a lot of people of alignment of the entire patient journey, which I think was important. I'm going to go around with the speakers and ask them, in a way, how do you define efficiency in your setting? And let's keep it sort of in the patient journey of arthroplasty surgery, from beginning to end. I'm not asking you, how you define efficiency in other settings. And in a lot of sense, how do you look at it at turnover, case start, scheduling? There's a whole range of things. So I'm gonna start with Brian, because I am also employed, and we don't do any in an ASC. So how are you first defining your efficiency? Oh, you muted, Brian.
I thought you were controlling everything. I think for me, efficiency really depends on, when I walk into a day in my schedule, finishing the schedule in the time that I've been given, because our cases, when you've been doing this for so long, you have a set time for the most part that's based on your own average. If I come in at or below, that means that I'm, at least meeting my minimum goal. But that's how I define efficiency. As long as the cases go and I walk out of the room, do my thing, walk back in the room, the next patient's ready. That's efficiency for me. So I try not to make it too difficult. Try to keep the goals very focused. And that's how it is.
I'm going to push you a little bit on that slightly and ask you, over let's say the last 10 years, have you, with a lot of changes that have been various trends going on in healthcare, have you changed your metrics of efficiency? Like if you used to do 4 cases by 4 o'clock, have you now tried to change things up a little bit and change your metrics?
No, I feel like we pack the day with as many as we can that's allowed during the time that we're given. And it's really based off of, average times. So it's really, it's hitting a point that I don't have control over that. All I could do is do my cases, and then, they'll drop the longest 3, the shortest 3, and average the medium middle 5. So it's kind of defined for me. I just want to make sure I work within that scope.
Mike, yes, you work in pretty large and like Bronx Care, nationally recognized facility. No, you work at a wonderful place, but you have your challenges, of course, a lot with multiple surgeons. So how do you personally, and maybe in your role at the hospital, define efficiency?
Yeah, so I think this has definitely been to the question you were asking Brian before. This has been an evolution actually for me over time, and I think for us, even at our large 52 OR, 130 surgeon facility, has been a changing definition over time. Personally, I used to say efficiency meant how many cases could I do in a day. Some of that had to do with like personal energy, like how much work can I do and how late am I willing to get home. And that was just sort of how it started. And I think that's the worst way we could do it. Like everything about that is terrible for work-life balance, for the fact that my kids recognize me when I get home, all these good things. So then I started defining efficiency as how many cases can I do in a day and make it home for dinner, right? So like to a little bit to what Brian is saying, sort of give myself a set time and how much work can I do. And I've gone away from that also because that really takes me out of the driver's seat of it. It leaves me feeling like there's a lot happening to me and I'm not controlling it. So the way I define efficiency today from a personal perspective is how much time can I spend at work working, as opposed to standing around waiting for the OR, standing around waiting for anesthesia, standing around waiting for the block, standing around waiting for any particular delay of any kind. So my goal is to come as close to 100% as possible. Meaning, can I spend every single minute at work doing surgery? And that's my goal of efficiency, because then I can change what time I leave, what time I stay, whatever I do. I still know that I'm utilizing the most important resource I have, which is me and my time. At the hospital, we've also recognized that there's so many challenges with so many complexities, case complexity, types of surgeries you do. Every surgeon's a little different. But ultimately, the idea became the same. How can we keep the surgeons operating as much as possible? Get away from the old way, and I'm sure, Ira, you remember these days where you did one case, then you went back to the office, wrote 3 emails, saw a patient, took a nap, wrote a paper, went and ran an experiment, came back, and the room was just being cleaned. Right? Like, get away from that and keep surgeons in the ORs on their OR days. And that kind of became more of the way that we started to define efficiency, which really changed the way we look at the way the day broke down.
That's amazing. I'm going to go to Atul, who's also at quite a powerhouse institution, Cleveland Clinic. For yourself, how do you define and maximize your efficiency, and maybe how do you see it happening at the clinic?
Yeah, the clinic, actually, we have the big tertiary mothership, where there's cardiac transplants and things happening there. So there's different sites of care, even within a large institution. I actually do probably 95% of my cases at a small satellite hospital, which is still part of the clinic. I still have, the world's best cardiologist, things like that are, everything's available. However, it's a little bit of scale as well, which I hope we can get into a little bit. So there's sites of care, even with the same institution, the same incentivization programs, the same anesthesiology pool. And then again, but I have the ability to control the efficiency much more carefully within a smaller site of care. So a lot of the high efficiency cases and volume is done preferentially in smaller kind of satellite facilities where I can literally see the front door and see the PACU, and I can see everything in between. And I think that's a little bit of what we talk about with scalability, but also efficiency. I think technology will help us bridge that to make the quaternary centers efficient as well, but that needs technology that's leveraged very nicely. I agree with a lot with Mike had said and Brian. I think historically efficiency was also a little bit of the speed at which you were doing things. So now we just heard that Brian, is a very efficient, very high volume surgeon, but, maybe his average times have not changed dramatically for what he does in the operating room over the last 15 years, but it's everything around him. It's the throughput. I think those are the major factors that builds efficiency. And end of the day, I agree with Mike. It's the amount of work product that you produce over a certain amount of time, right? Whether you produce 10 widgets in 6 hours, or you produce 10 widgets in 12 hours. Really, that's the efficiency, is really that amount of work product divided by the time you do it in. And now that's a little bit of how we can, kind of discussions around that as well. There's a little bit of alignment built into that. And the other concept from an efficiency standpoint is really it's the surgeon idle time, and the numerator is actually how much surgeon is producing, or actually the hands are working. So I think that's a huge piece of efficiency. And I think broadly, we have to stop thinking about utilization metrics. And I think we'll probably dive into that today. Utilization metrics, I think, is historically what we were kind of really trained on, and that's all we did. And now I think we have to frame it in these definitions of efficiency metrics.
That's great. Kyle, you are in a unique position as a high-level administrator, vice president of finance, an ASC. What is your view of it from that angle? Because you're working with, SPD, you're working with vendors coming in and out, trucks coming in. The surgeons are seeing turnover time and possibly some other things. So from your point of view, what's the efficiency model?
Yeah, it's such an interesting topic because I think it starts at the root of what everyone has described already, which is what is the overall output of the day, right? When we're trying to, from a business perspective, drive case volume, drive revenue, et cetera. But when we enter the efficiency conversation, it starts to introduce the concept of, well, at what cost did we achieve that, right? And what is the repeatability of what we did today? And if we're going to be successful in the long term, we have to be able to repeat this over and over and over again. And when you think about process and efficiency, that's exactly what each of the steps broken down are, right? Is can this person repeat as effectively as possible over and over and over again so that when Mike goes downstairs, he comes back up and the room is already waiting for him, right? And he comes in and he starts to do his thing. And when you think about the different steps of the process, you realize that efficiency itself is not about doing any of the individual steps faster, right? The point is not to move faster in what you're doing. These may be the things that you need to do, but are you being efficient in what you do? And I think that, from my perspective, as I'm looking over the different departments of the surgery center, looking through the entire life cycle of the employee and the patient journey, it's my responsibility to think about repeatability. And sure, we can drive this and we can operate above peak efficiency, but we might only be able to do it for a week or a month or it's a quarter. And then all of a sudden we have a staffing problem. And then when it's time to put the surgeon back in the OR, I'm down 3 surgical techs because we operated above peak efficiency, right? So when we think about setting up systems, establishing the data to support the decision making, that's how I think about it. And I look at efficiency as what is sustainable? How can we achieve the highest level of throughput and to maximize the rate limiting factor, which truly should be the surgeon that was previously discussed. And how are we looking at it as in a holistic perspective in order to achieve that outcome?
And Lacey, I'd like you to bring us home on this one from your experience as a vice president of clinical operations, surgical investors, advisors. You've seen a lot of change models out there that have gone from inefficient to efficient, from efficient to uber efficient, and maybe saw some that lost their efficiency. So how would you define that efficiency, and where is this trend now? What are the pain points now?
Well, when we started, we used to talk about in the ASC. So that's a different market than a hospital or HOPD. That's a business that is, a profit business. We talk about having our customers was our original idea, was that was patients, surgeons. How do we make our customers happy? Making a surgeon happy and a patient happy may be a little bit different. So a surgeon wants to bring his patients in. I've had it, presented, bring all 6 of them in and I'll mark them and we'll go through the day. But that's not a patient satisfaction piece. And we're now seeing that the market is we're about to be linked into patient satisfaction. Get ready, because that's going to be your payer. How are we going to get paid? Is the patient satisfied or not? So to me, I look at the doctor, he wants to start his cases on time. How do we do that? And that's, bringing 2 people in at the same time, getting them ready in case somebody's late, those kind of things. But then how do we satisfy the patient? So we do a lot of metrics to say, how long are they in the waiting room? How long are they in pre-op? Those kind of pieces matter to other people than the surgeon. I will not delay a surgeon. That's my ultimate goal. He needs to start each case 1, 2, 3, 4, 5, all of them on time. And it's our job to figure out how we bring them in and make the patient satisfied with that. So it's been a change over the last couple of years. And I just say the data that you have, a surgeon can say it takes me 20 minutes to do a shoulder, and it does, but the room is taken up for an hour and 20 minutes. So we have to have that data to show him when to bring patients in, how to make patients satisfied. So I'm a little different than y'all. I'm not just the OR. I'm looking at all of the pieces, get them in, get them operated on, and their recovery time.
We had a question, Thomas Caramadre. Would you like to unmute and give your question to Dr. Brian Cohen?
Sure, thank you. Dr. Cohen, I just mentioned as an employee, are you incentivized to be more efficient? Is there, is there some sort of a program in place that drives, whether it's monetarily or whatever else, you to be more efficient?
There's no, I mean, having been in this for so long, everything is production based, so I guess the more I do, the more I get paid. But, once again, it's really what I've done over my career, and I don't want my patients coming in all at once. And if I have to wait because I finished early or somebody canceled, that's just what I have to deal with. I'd rather have a happy patient, because the last thing you want to do is operate on somebody who's not happy. And if they're pissed off because they came in 2 hours early, it makes everything just more challenging. But the efficiency for me really starts in the office. We're very fortunate. We have 8 non-operative sports medicine doctors that do a very good job of triaging operative versus non-operative cases. So, it allows me to operate 4 days a week. There were years where we were doing 2,000 plus cases. That's a mix of, total joints and sports and not 2,000 carpal tunnels. But once again, I like to operate. So that's where the benefit for me is figuring out a way to create a mousetrap that works in my favor, with people that are all pulling in the same direction.
Thomas, you bring up a good point. Who, by the way, Thomas's name is actually Joe. So Joe, you bring up a good point. I think Atul talked about this a minute ago, right? The problem is actually most hospitals disincentivize efficiency because they use block utilization as their metric. And this is exactly what Atul said earlier. Block utilization is a terrible metric because we have a surgeon at our hospital who complains about this often. He is one of our most efficient surgeons, does an incredible job, technically excellent, and got his block time taken away because he was finishing too quickly, doing more cases than anyone, but happened to finish because he had a good team, aligned in their incentives, did the right thing, moved efficiently, highest volume of the day, finished before everyone else, and he was penalized for it. The opposite of what you're saying, right? He was actually penalized for it. And so I think it is critical that we get away from those types of metrics. They really are not useful. It's just like the metric of turnover time. Turnover time means nothing to me. I want to know how long from the moment I walk out of the OR to how long till I make my skin incision, right? The fact that the room happened to have been cleaned doesn't tell me how long anesthesia took, setup took, or how long it took me to start operating again. And so I think we need to start to move away from these traditional metrics because they're actually, they're not, it's not that they're just like okay and not good enough. They're actually counterproductive to the ability to truly be more efficient.
Couldn't agree more. You are so right on. That's the thing. Get away from the hospital, metrics, and really put these out for things that you need to use for your case day.
Yeah, I remember when the last meeting, Charlie DeCook said that in his metrics, he found that wheels into incision was the longest time waster. Okay, is that everyone's experience, something like that? Wheels into incision.
I've been measuring that for 25 years because that's the piece. Is it anesthesia? Is it the prep people? Is it the doctor? That's the key metric. How long does it take you to make your incision?
And when we started to look at that, we found out something really interesting. Just again, a little bit of it is like a cultural thing that you see in hospitals, right? What we found was the biggest time waster was actually wheels out to wheels in because they were waiting until all of the instruments were completely set up. And if they needed like another tray, they just waited until that tray came from SPD. And then they brought the patient in and started 35 minutes of anesthesia. Right?
That's a scrub tech defining your time. You do not do that.
Some of it's just that was the culture at the time, right? One of those things. And one of the simplest things we did when we tried to change our efficiencies was tell them the floor is dry, bring the patient in the room. Set up while they're doing anesthesia. They take about the same amount of time. And if you can get rid of blue wraps or do other things that are helpful, that's great. But realistically, just learning to parallel process and stop thinking that just because the patient eventually got in the room, that was good enough. Like that, I think that's really where we start to push these metrics to be things that are actionable.
And that is true to as far as staffing. That's a leadership thing to say we can do that. We do not have to wait till you have everything ready. You know, even if they got a hole in a wrap, we have extra trays. Don't, you know, that's the old thinking. Don't let them do that.
We have another question from John V. Solanki. I hope you're available to ask your question, John V.
Yeah, I think it was more of a comment. I know the conventional OR metrics have sort of failed us in some of the efficiency work that we've been doing at our hospital. Sorry, we're a Canadian hospital, and this is all a first for us. And one of the things that we've started looking at is completely different scores, and most of our Canadian colleagues don't agree with us, so it's a little bit interesting. But we're looking at two different metrics. We're looking at a surgeon efficiency index and a root efficiency index versus the conventional OR metrics and things like that. And there is a little bit of scant literature that we found using some robotic surgery, and so that's what we are trying to implement. So yeah, I'd be very interested to know if any of the other centers have tried anything like that or utilized different metrics.
What are your numerator and denominator for the index, for the surgeon efficiency index you're looking at?
So we're looking at sort of overall minutes utilized, number of cases completed, also the number of delay minutes as well, because we do have delay minutes as well that get compounded into all of that. We also have recovery times as well that are sort of part of that because they get compounded into our overall metric in our Meditech system as well. But essentially, we're looking at those two components primarily, and then we're looking at, for the denominator, we're looking at overall number of minutes and overall number of cases. But we're still perfecting it because we're trying to make this a little bit more of a weighted score. So that we can look at that, and then that's mainly what we're looking at. Room from a surgeon perspective, we're looking at also numbers, like the number of minutes that the typical minutes for that surgeon for the type of procedure that we're doing, unless there was a complication. So for typical and atypical procedures, we're defining it so that we can measure them on the same efficiencies for each procedure. It's the repeatability aspect of it that we're looking at as well.
I'm curious. I wanna that is a great comment, Dr. Solanki. I really appreciate that. And you know, what you mentioned something that a number of you imply that a number of the other Canadian surgeons are not happy about this. So you know, all successful ORs are successful the same way, and all unsuccessful ones screw it up in their own unique way. It's a play off of a Tolstoy quote. So I'm really curious to go back to whatever Joe Caramadre's real name is, Ashley. The idea very much of how do you set up incentives? Are they internal incentives? Are they financial incentives? Are they group behavior, you know, it's not always a carrot and a stick. Because part of this thing tonight is achieving your goals. And part of achieving that goal is to figure out how to execute the great plan. You know, you have a great plan, and then all of a sudden 6 other people have different incentives. So anyone want to take that on about incentivizing people? And it doesn't have to be financial incentives, you know.
Yeah, I'll take it on a little bit because we, you know, in our system, it's a little bit fixed in some of the incentives that are, you know, in sort of the programs that we have in terms of nursing, anesthesia. But, you know, we tried to build, and it's a little bit of, you know, there's people versus process. And I think also we can fine tune process. We can talk about some of the tech behind optimize that in a little bit, but a lot of it's, you know, the people that we've built around that. So we tried to build dedicated teams that have pride and culture associated with what they do. And I think there's different ways to incentivize people. It's money, it's, you can get done early and, pick up the kids from practice or go, coach lacrosse or whatever it is. But it's also the culture of people are really feeling that they're producing something that's a little bit more high quality, a little bit different, a little bit better patient experience. I think that goes without saying. It's a little bit more of the intangible. It's harder to quantify, but I do think that's a huge driver of, why someone would work harder in a fixed amount of time. And we've sort of been able to create that. And then to Mike's point, you do it too well, and all of a sudden you sort of are 50% utilization for some reason, but you've done 10 cases, right? So it's a little bit of then working with that particular or administration area to say, listen, if that team is, producing 10 widgets that day, they're not going to be backfilled with the urology case, or they're not going to be backfilled with some other type of service line. They are there. And if they're done by 1 o'clock, that's fine. If they're done by 1:30, that's okay. And, it's a little bit of their balanced load throughout the week. That takes a little bit of just foresight and planning and just getting everyone on the same page. I think also with anesthesia, right? So there's anesthesiologists who are very slick with blocks. We do them in a holding area, so they're all done ahead of time, so they can do their block, they can do their spinal. We wheel them in and we start to operate. But again, they have the ability, the luxury, the time to balance it out with their CRNAs to do that efficiently, so they're not rushed, and they sort of can do bill for their procedures accordingly. So I think it's incentivization. It's the alignment piece that was talked about in prior webinars. And I think that breeds a little bit of the efficiency piece on the tail end, but it's a balancing act for sure.
Other comments?
Yeah. For me, I think it's about leading by example. When I'm operating, that's what I'm doing. I'm not disappearing for consults. I'm not going back to the office. I'm not going downstairs for lunch. If I'm done with my dictation, spoke to the family, marked the next patient, did all my prescriptions, then I'll go in and I'll help turn the room over, and I think that stimulates the team to understand that, look, if he's taking his time to work with us to get things done, we're going to take our time to work with him. So, I could have the same staff that 2 days before was blamed for, 30-minute turnover time. And, we're turning it over quicker than that. But I really think it's, people gravitate toward the, the personality of not the leader, but the surgeon, in the sense that if I'm disappearing, then they'll go take lunch for 20 extra minutes or something. So I just really feel like if you're pulling in the same direction as your team and kind of leading the pull, they tend to work a lot more efficiently and they feel better about the day.
And I'll say that answer is the most important one, right? That goes back to what we sort of talked about at the last webinar, all about building that culture of efficiency and doing that. But data doesn't lie. And when you've got data on the things that Lacey was alluding to earlier, how long does it take from wheels into incision? How long does it take from wheels out to wheels in? All of a sudden you effectuate change. And when you show anesthesiologists that have been resistant to doing block rooms or something, that the longest part of the case is their time in the operating room, all of a sudden they might change their mind, right? When you show consistency and you're able to create metrics that are measurable, comparable, and repeatable and consistent, I think all of a sudden then you can have a very different conversation, as opposed to sounding like the surgeon or the administrator or the manager who's just stomping their feet in the corner saying, I think this is taking too long, right? Like when you have real data, I think it really helps even the biggest naysayer say, oh, you know what? That's the data. Now we can do something about it.
Yeah, I think Mike hit that right on the head. I mean, I think transparency in this process is really changed a lot of this. Things like Ospitec, the platform, I mean, we really have real hard data to go by. I think a lot of the surrogate metrics that we're talking about, utilization metric is like a surrogate metric. It's something you can review at 30 days after or monthly and say, this is the utilization rate. But real-time metrics, like how much is the surgeon's hands moving versus the whole day. I mean, we never really had this real-time data. And I think that's where it's been a game changer to have that visibility and the transparency. And I would say, like the hospitals, we talked about HOPDs and hospitals and ASCs, right? The hospitals have the most to gain by transparency and real-time data, as much as an ASC. So I think this is really going to be a huge frame shift. But again, the data transparency, I think Mike hit on the head. Yeah.
Yeah. To show your staff you're 4 minutes behind the prep time, it makes them move faster and go, okay, gosh, what did I do? We need to move quicker to make that. There's no reason to not be on time. So yeah, it's been the data it saves a lot of arguments with anybody.
And what I would add in terms of incentivization is that there need to be two elements. One, it needs to be sustainable, right? And so everyone is incentivized by financial rewards. But does it work every quarter? Does it work every year? Does it have to get bigger every year? But the elements that can be achieved with efficiency with regard to employees' quality of life is something that is ongoing, right? And so that's one, is that, to the point made earlier about you can't ask for something and then backfill it so they didn't experience the benefit of that efficiency as well, right? So is this a shared benefit in efficiency? And then I think the second part of that obligation is to provide them the tools to be successful, right? So the older and traditional review of the performance doesn't encompass what is required to improve them necessarily, right? So there's this difference between the macro data and the micro data in terms of that person might not know that they are falling 3 minutes behind, 5 minutes behind, or they're aware, but they don't know how to fix it, right? And so when it comes to data and data utilization, collecting it and then making it actionable to all of the stakeholders, whether or not it's the surgeon or SPD or the surgical tech, what have you, that's when you start to really drive true change, and then everyone can share in the benefit.
And I'll just say, just so you know, I mean, in the ASC, it's sort of a little different because hospitals have so many layers, but in the ASC, it's to really say it's a team. You cannot get a patient in the room unless pre-op works efficiently to get them ready to go back to the room. You cannot turn your bays over unless they recover them and get them ready for the next set. So it is not, you can't just look at the OR. You have to look at the whole team.
Yeah, I just want to do a little bit of a shout out. There's no efficiency discussion that cannot be really discussed unless we go back to this article, which was Charlie DeCook and Jeremy Sten. I'm sure you guys could see my screen. 12 by 12, obtaining true OR efficiency with radical time transparency and operational excellence. This article has already been read, or at least viewed, 18,759 times. 759 of those are my cousins in Brooklyn. So it's pretty good. So a little shout out to that. So I want to talk about investment. Hospitals like to invest in all kinds of things: robots, hospitals, ASCs, new Arthrex toys, that wasn't a shout out to Arthrex. That's a company that sells a lot of toys. And in reality, how much do you think your hospital invests in efficiency? And if they don't, where do you think the barriers are for them to invest in efficiency? Okay, Lacey, you want to take that on maybe?
So sure. So for us, our company, it's a mandatory that we have an Ospitec system in because it's simple, easy. I mean, we can get a ton of data really quickly. We're dealing with all kinds of platforms, Epic, Cerner, everything. And I've found that none of it gives you true data because you're always waiting on somebody to click it. This is a real time. Where are they? What are they doing? And it's a game changer for us to be able to provide that data to our surgeons and say, this is how much time they're spending in the waiting room pre-op, those kind of things. So it's huge for us.
And Eric, I mean, Kyle, I was going to ask you specifically, not just investment in technology, but investment in people, maybe more people clean the room. How does that go over with a vice president of finance?
Yeah. It goes back to the importance of the data, right? Because when you're making these types of decisions, you have to be able to justify it. And we can't have people waiting around. We can't have, people getting lost. We can't have things that delay. And so is there an opportunity to invest further in both technology and people to make the space more efficient? But in order to make that decision effectively, you have to be able to substantiate it in some way, and you have to be able to identify what the expected return is, right? And so it could be that the return is additional cases. It could be that the return is improved efficiency that will decrease the effort to perform those cases. It could be that the return is improved patient experience or physician or employee experience. So in terms of being able to quantify it, it can't be just my day seemed a little bit better, right? It's the and Mike said it earlier that the data doesn't lie, and that's why we have it. It's to either support or refute decision making to make sure that we are doing what is the most effective in order to operate the center. And it's not just the pace of the surgeon, but where do we require additional resources in order to be more effective?
I think, Ira, we also spend a lot of money on what is perceived efficiency, right? And I think large kind of complex systems, you also think of things like an Epic or another sort of data dashboard where it's a huge upfront investment. It's hard to update in real time. It's hard to update, when the contracts are moving. So it's a little bit of, as Lacey had mentioned, low tech, highly integratable, real time. I mean, something again like Hospitech that provides that is much more bang for the buck than a $500 million investment in a data platform that integrates with a hospital. But again, the data dashboard that it puts out is refreshed every 30 minutes or whatever, so it's something where I think you have to really look at the lean nature of it, as well as the integratability. And in Internet of Things type wearable device that real-time tracks, I mean, I think that's where, again, we're feeding off a lot of these transparency.
We had a question again from the man who has no name, Joe.
And like transparently, I work for one of the device manufacturers. I work for DePuy, and but and a lot of our customers are moving towards the ASCs, and I mean, the implant costs can only go so far, and we have to look for other ways to bring value to them. And so, we do look at things like Hospitech, whether it's a DePuy product or not. How can I bring value to my customers? And what I was said in the question was, sometimes it's a struggle to help them quantify what the savings could be or the efficiencies could be, and because it is ambiguous, as was just stated, right? It might be a quality of life thing, it might be multiple things, but I have a group now that a surgeon loves Hospitech, but how does he explain it to his partner that they have to pay even $1 for anything and when they don't want to pay anything? So I guess that's one of the struggles that struggle is the wrong word, but trying to just wrap my head around how to present it, in an ROI type of scenario.
Well, for us, you talk about reducing your trays. You reduce, what you need. We've done a lot of work with providers to make those trays get lower, and we're not saying you don't provide what we need, but we just say on the 90% of the cases, we only need 2 trays, and those kind of things. So, and we're all looking at offsite sterilization, all those kind of pieces. So that's the piece that the vendor can bring, aside from the standardization of either 1 or 2 implants per center, or however you're going to do it. That's my take.
Mike?
And I agree 100%.
I also think, though, this is where all of us who are getting involved in the business side of these decisions need to get away from 6-year-old accounting. When I tell my son I'm taking away your toy, that's all he hears. I'm taking away your toy, right? It's the same thing when we start to have these conversations. We're going to spend $10 in the surgery center. Oh my gosh, we lost $10. But if that $10 allowed me to do 1 more case, I made $16,990 by spending $10, right? And so when I start to talk about costs, you just can't allow the conversation to end at, well, that cost us some money. So let's just talk about tech for a second, right? So let's say tech, to just dial it into unrelated to efficiency, right? Let's say tech allowed you to achieve what Lacey just described. Let's say if I spend $1,000 a case on tech, but it cuts 3 trays out, and 3 trays cost me $600 to sterilize. Well, I spent $400, right? Maybe $400 was worth it. I don't really know, but don't tell me I spent $1,000, right? Like, you just can't allow the conversation to end that simplistically. That's a person who's just not interested in actually learning how the business works. So if you've got a technology or a human being, let's just say you did hire that 1 extra person who helps turn over the room quickly, and that FTE, that $30,000 a year plus benefits, so you're spending $55,000 a year, gets you one more case per day, twice a week. They've paid for themselves in a month, right? Like it's not even, I'd hire 100 of those people and see if I could do 20 more cases in a day, right? Like you have to recognize that the accounting, especially in a surgery center, where overhead is not that bad, and you're not sharing it across the secondary service line that's losing money, like it is always worth it to spend a little more money. And so if you bring to your partners, Joe, if you bring to them like, hey, I've got this technology, this whatever, and you're going to spend X, and it's going to allow you to do one more case that reimburses at 50X, you should probably take a look at this, right? And that's the way that all of these expenditures should be looked at, especially in the ASC side. But even in the hospital, I tell my hospital the same thing. Just because hospitals have traditionally been run like child's piggy banks, where every dollar spent is a dollar lost, that's not actually how healthcare works. And it's way more complicated than that.
I think it's an amazing point. I think that one of the things that periodically in my hospital, the CFO or the CEO will push back on, we want one more tech or we want something else, is what I call the trustworthiness of results. In other words, they'll point back to a program done 2 years ago where we bought this and we were promised to do more cases in a day, and we didn't do more cases in a day. And I think we have to be honest with each other when we say that we're going to bring in tech and we're going to do more cases, or we'll go home earlier and save overtime. But you really have to be prepared to show when you bring something in and you spend, to show the ROI, because you'll lose trustworthiness with the decision makers. I mean, what do you guys think about? I mean, Kyle, if a surgeon came up to you,
Yeah, so I think that one of the things we run into in these circumstances is we are not specific enough about the expected result, right? And sometimes the expected result is not, or the result is not what you expected, but it doesn't mean that it's not positive, right? And so it goes back to understanding what you would like to achieve first, and then trying to identify the tools, processes, or people that allow you to achieve that goal. So, one of the examples we've discussed is, if I could add 100 more people, that's great. I could do 20 more cases. Well, if you introduce the right technology, you might still be able to do more cases, but with less people. And oh, by the way, $30,000 of technology versus $30,000 worth of people, technology doesn't call out, right? Technology doesn't have to take vacation, and so all of a sudden there's this introduction of, coming back to the why of why you would introduce additional technology or alter and adjust your processes to help to justify that. And it can't just be about spending the dollar. I couldn't agree more with what Mike just alluded to, because it's either about making money or spending less money, right? And frankly, I would always prefer to make more money. It feels better for everyone. I think it's the fastest way, obviously, to move up and to keep the shareholders happy. But I think if you don't have a good why, and if you don't take that justification and have a clear expectation of what the result is, yeah, it's hard to get on board with spending additional money, especially if things are going well.
But I'd like to sort of go into a sort of a psychological part a little bit of how do you start an efficient culture? There are many hospitals and even many ASCs that are not as efficient as others. Where do you start that? Lacey, where do you start? You have focus groups, you take them out to beers, what do you do?
Well, yeah, I'm not a big fan of that, but yeah. So we start with where they are, and then we talk about how we incrementally increase or make their life, make those efficiencies better. It's not, nobody likes change, so it's really just sort of turning the ship, incrementally, and we find out where their value is. Do you want to get home earlier? Do you want to, do you want to have more time? Do you want to come in later? What is it you want to do? And it is a tight deal. I will say, certainly in this, culture today, we've got to make some improvements on how we're going to keep nurses. So our method is we do 10-hour shifts and everybody gets a day off a week. That's the way we work those things. And then we make a culture where you're out, somebody's got to cover for you. Let's all work together. And it's worked well for us. It's a trust and a respect issue of our staff, and they know that their management and the surgeons will back us up. So
Some other comments from the faculty? Yeah.
I was going to say, I think bringing the stakeholders together, like Lacey was talking about, I think also kind of breaking down the steps of the process, I think is very helpful. Another piece, and I think it goes to Joe's point from before, or this question, is standardization. I think that's pretty important, right? So if a few of his surgeons that he's talking with are like, well, I don't really know about tech, or, hey, I want this device or not. I mean, if you're, especially in an ASC, you got to have, in my opinion, if there's 10 surgeons, you really have to have standardization across the board. So if one tray is not unsterile or something's happening, I can literally open a tray for the procedure, for a total knee procedure, and me and any colleague can work on that same thing. So standardization, both on that or the utility of tech, the staffing models, I think really have to get everyone, in the same message on kind of the philosophy behind it, as well as how you're going to implement it. So, yeah.
Brian, you have any ideas on the idea in your kind of model, how you start a program of efficiency?
Yeah, I recently transitioned from one employment to another in the last 3 years, and I can only control my own sphere of, where I'm working, and I honestly believe that for me, the benefit is how you treat people. It works for me, and it also works if I'm a participant in what we're trying to do. I said it before, I'm not above carrying trash out. I'm not above mopping the floor. I'm not above wheeling a patient to a room. And I think that people learn by example, and being a new surgeon in a new facility, and then having people come up to you and say, can you kind of talk to some of the other doctors about how to do this? It works for me in my world, but because I can't control the rest of it. I can only control the people that I work with on that day, and it can be different people every day. So it's just, until I'm part of my own thing, which we're working towards, I really just have to focus on the world that I live in.
Excellent.
Yeah, I couldn't agree with that more. The example that the surgeon sets that acts as a catalyst for the team can't be overstated. I'm in a very fortunate position that we have phenomenal nursing staff and phenomenal surgical techs. They work incredibly hard. The support staff works incredibly hard, and they will move even faster if they know, see, and respect that the surgeon is buying into what they're doing as well. To the point about, and I've heard a couple of people say it, picking up a mop. Boy, what a difference that makes when everybody's in it together, that collective feeling of what it is that we're trying to achieve from the outset, really keeps even the most motivated groups going.
Good. I am going to show something on my screen again as we get to the end. This was sent by Tommy. I'm sure people can see it. OR performance. I think this is an OpsiTech screen. Am I right there, Lacey? Right? And it really shows.
We use it. Yep, that's ours.
Yeah, it's yours. Okay, and so that really shows a tremendous amount of transparency data. Okay. I'd like to sort of close it out a little bit by just going around the horn one more time and sort of ask a question about, again, what do you feel the barriers? I mean, I'll start with Mike, because Mike, you're Chief Innovation Officer now at Special Surgery, and that could be a challenging role with the kind of egos and personalities you have. Yeah. Yeah, it's no problem. You just mention it and everyone everyone just shows up. But let's take a technology like Ospitec, okay? And say someone came up to you, it's a new innovation. Where's the major barrier?
I mean, I think the major barrier to anything is always resistance to change, right? And especially in large organizations, there's no question. Even in the quote most nimble large organizations, I would say a lot of them are like steering a cruise ship. Right? They turn, they just don't turn fast, right? So you better start turning them early. And so I think resistance to change and that cultural inertia is a real challenge. And the only thing that fights it actually, and the reason that my innovation role is so much easier than anything in the OR is that it's the surgeon champion that changes it, right? So when the surgeon champion is the innovator and comes to me and wants to do something great, I've got the person that wants to push this forward. So when our surgeons want something, things tend to happen. I think Brian is a perfect example of exactly what that looks like. When the surgeon shows up and maybe they're at a new hospital or in a new situation in a place with that inertia and no interest in changing or significant resistance to change, when the surgeon changes it on their own and he or she says, this is how I'm going to do it by being the leader of the ship, all of a sudden it changes. Because it's just the general resistance to change that really becomes the only excuse, because everything else makes you want to do it.
Yeah. Great. I want a tip from everybody. We are miraculously an hour has gone by, as it always does in a good episode of Suits or something like that. But I want to give everyone to give me a tip on how to bring in a technology like it doesn't have to be an Ospitec. There are a variety of other technologies, but a tip on how you would bring it into your organization. Atul, you want to start off, and we'll end with this kind of tip on how you think the method you bring it in.
Yeah, I think the beauty of any new tech, bring it in. Ospitec here is an example, right? If it can run in the background and it does its thing and it's helpful and it's not intrusive, it's not some big structural thing. If it can do that, that's probably the most elegant tech that we have, right? You showed one image of a real-time OR stat, right? And pictures speak 1,000 words, and you show that to a surgeon or a surgical team. Now you can start constructing where you need to make the most benefits, where you are lacking. But again, a very elegant thing that's running in the background in real time, and it's not obtrusive, it's not expensive, but it gets the most return on your efficiency metrics. That's the way to kind of do it in terms of a tech that really is low profile but powerful.
Lacey?
So for me, it's trusting the data. So how many times have you been in a room and everybody goes, what time did we come in? And everybody just comes up with a number that they came in the room. It's not true, but you're all agreeing on it. And what time are we leaving? So this, for me, Ospitec leaves it all, there's no doubt that patient came in, they left. It's a trust. I'm working with a ton of, systems, and there is nothing like this to say, this is when we came in, this is when we left, this is where they are. You trust the data.
Brian, a tip on getting things adopted that you want?
Yeah, unfortunately, since I've only worked with hospital administrators, I'm 0 for probably 100. All these suggestions are perfect, but talking to people who just don't care about real data or real patient safety, or it's beyond me.
Yeah.
Being told that you can't use something that's shown to be proven for patient safety, and when you ask who the decision makers are, and none of them are surgeons, it's very frustrating. So I'm at a loss. I would have thought that logic fits here somewhere, but it doesn't.
Kyle? Yeah, you're right on. I get it. Yeah. Kyle?
Yeah, I would say that it's important when you're evaluating new technologies like Ospitec that not only does the technology allow you to grow exponentially in the future to achieve your goals, but it also will allow you to create a bridge to get there, right? The graphic that you showed previously indicated and highlighted turnover time, right? Which is a metric that several people on this call denounced. But the reason that it's effective is it speaks a language that everyone understands, but then breaks it down into the elements that actually drive change. So can the technology vault you into a new space, but also does it get close enough where you can understand and you have the decision makers that Brian just alluded to, and everyone is speaking the same language so you can get to the place that is actually going to catapult you into the future.
Mike, I'd like you please bring us home with a summary statement for tonight, if you can.
I think the summary for tonight is number one, there's a lot of opportunity here. I think all of us recognize that there's huge opportunity to improve efficiencies in what we do, no matter how you define it, whether that is getting home earlier, whether that is higher levels of patient satisfaction because they're not sitting around the center so long, whether that is getting more cases done in a day, whether that is better relationships with our customer bases or our patient bases or our surgeon bases, whomever it is. I think there's a lot of ways to do it. But as we start the conversation to sort of finish exactly where Kyle said, it's now our turn to define the language. Let's start speaking the same language. Let's use metrics that are both measurable and actually useful. And then let's look for opportunities where everyone wins, right? Where it wins on the finance side, it wins on the happiness side, it wins on the culture side, it wins on the patient care side, right? And if we can do that, if we can turn this yearning that everybody kind of wants to do it better but doesn't know how into a language we all speak in a simple app and a simple way to apply it, I think in the end, all of us are better off, all of us are happier, all of our patients are having a better day, and there's nothing more important than that.
Excellent. And with that, I'd like to say thank you to our panelists and thank you to everyone who joined us tonight. And good night. It was an absolute pleasure.